I'm pleased to present Dr. Emily Winslow, Professor of Surgery at Georgetown University Medical School, who's going to be talking to us about Whipple procedures, pancreaticoduodenectomy, and imaging. And one of the reasons that Dr. Winslow has graciously decided to educate us today is because last time we had case conference, I presented a case of an omental infarct after Whipple, and it was something that I wasn't really aware of how often we were doing them and why we were doing them. And one of the participants, Dr. Ross Felice, started asking Dr. Winslow about these, and so she volunteered to give us a lecture. So Dr. Winslow, take it away. And if anybody has questions, please write them in the chat box, and I'll ask them either during the lecture or at the end.
Perfect. I'm going to try not to lecture too much, but just show some good pictures. And then definitely I'm happy for anybody to interrupt at any point, because it'll probably be more relevant during the slides. So, okay, so this is what I was hoping to do, just go over some things that are kind of surgical about the preoperative imaging. Obviously, there's much about the preoperative imaging that we're not going to touch on, but the most relevant surgical issues, and then just review a little bit about some of the anatomical issues in the OR that influence the imaging that comes postoperatively, and then try to just show you a good case example with a film and some discussion based on some other films as well that people have brought. Okay, so this is the one point I'll make. I think this is really important, that for us, understanding the preoperative imaging, putting it with the findings in the operating room, then the pathologic findings, both the gross and the microscopic ones, and post-op imaging in the clinical course. This is like a continuous cycle. And for me, I try to get the residents and fellows after a case to go back to the pre-op image every time and try to understand how what they saw in the operating room was reflected in the preoperative film, and a similar thing on the post-operative image. To me, like, this is about the only reason to be a surgeon, because all the other fun part is what you all do. But for us, trying to link all of that is I think the best way for us to both understand the disease, but also the anatomy and relevant imaging findings. So, okay. So for preoperative imaging, the things I wanted to touch on that I think maybe many of you will hear surgeons ask repetitively, because they're very relevant to the operative technique or on this list. And I'm going to kind of go through these one by one. But I think probably first is really not just the tumors in the head, but like exactly where is it in the head? And this idea of the neck versus the uncinate and the cranial part of the pancreas head versus the caudal part, I think is really important. And I think maybe this diagram shows it best. This is just a posterior view, obviously, of the head of the pancreas. And if a tumor's here in the medial part of the uncinate, that's a completely, much more difficult problem if it's on the right side of the vessels, especially, than if it's a tumor over here. These tumors they can be big and they're not as problematic. Even one that's up here on the neck is a different approach. So I thought I'd just try to explain that from a surgical perspective. And by EUS, often these two parts of the pancreas are similar to them. They're looking at them and they can't really tell, is this coming from the uncinate or coming from the neck? So a tumor will be described on EUS as uncinate/neck sometimes. And that, for us is confusing, because we have to figure out which operation needs to be done. So this is a surgical photo after the Whipple specimens come out. Okay, so the head is up at the top of the screen, the feet are down here, and then this is the patient's left side. This is the pancreas neck, the kind of the body where we've transected the neck right on top of the SMV. And basically, this is the mesentery. So this is the SMV that we've pulled off of the specimen, and the SMA that's exposed as a result, and obviously the cava and renal vein. And this is the gastroduodenal artery. So the difference is, in a neck tumor, the problems are all up here, very far away from where they are down in an uncinate tumor. And then similarly, the cranial part of the head up here is a different problem than often a caudal tumor. And for us, the caudal tumors are much more difficult. This is what the specimen looks like, and this is what I mean about trying to link the three views together. This is the neck that's been transected. This is the pancreas, and this is ink that we've put on afterwards, but this is ink where the SMV used to be. So this blue was hugging this vein, anteriorly and posteriorly, and then this red is where the SMA is located in the patient that the tissue came from. This, the head and uncinate, is where the transverse mesocolon is attached to the head of the pancreas. So these are all, when we're thinking when we say where's the tumor, we're really thinking about this. Like, is it going to be up here? Is it going to be in this part? Or am I going to have a problem here? Or is this a mesocolic issue? Okay, so, and then the artery situation. So this is a case that illustrates this problem well for us. This is a neck tumor in a patient, and I don't have great images of it, but this is the tumor, and this is the common hepatic artery. You can see our radiologists try to help us with big arrows, but here's the common hepatic artery. And this patient, has involvement, tumoral involvement of the artery, but importantly has a replaced right hepatic artery from the SMA and has a replaced left hepatic, or at least accessory left hepatic from the left gastric. So that means we can have a different operative approach, where we can transect the common hepatic here and take it back and remove the whole celiac trunk without having any issues related to arterial flow, at least. So the existence of replaced or accessory vessels and where they come from is really important for lots of reasons, not just when there's arterial involvement, but also can help us know what part of the liver may need to be sacrificed. So this patient, for example, the segment 4 artery does come from the common. And so if we do this, this patient's operation is still coming up, then we know that we'll probably have some segment 4 arterial ischemia, but that in general will be well tolerated. So, okay, so that's the arterial issues. And then in addition to knowing if the arteries are replaced or accessory, we also want to know where are they relative to the bile duct. Normally, obviously, the right hepatic artery, when it's coming from in the usual anatomic position from the common, comes underneath or posterior to the bile duct as it makes its way to the right liver, but not all the time. Sometimes it goes anterior, and we can figure that out in the operating room, but it is nice to know it ahead of time if there is a fair amount of portal inflammation or difficulty, because we're going to transect the bile duct right about that level where the right artery passes behind or anteriorly. And obviously, if you know to expect it anteriorly, it's a little bit easier to find it. There's also this variety of artery, which is hard to show in just a couple of screenshots, but this is a retroportal right artery that comes from the common. It's not replaced, but it goes behind the portal vein and then up along the right lateral aspect of the bile duct like a replaced right would. Here's just an axial image of it. So it looks on this film like you think it's going to be coming from here, but it's not. It goes up and it comes from the common. So if you were kind of filling out a checkbox, you would say, okay, well, the arterial anatomy is normal and there's nothing replaced or accessory, but this will, to us, act and be just like a replaced. Okay, so what about the celiac? I think one of the most problematic things for us not to notice on the preoperative film is a significant celiac stenosis. And obviously, in this case, I've pulled a nice obvious one, but you can see that there's lots of arterial collaterals in the pancreaticoduodenal groove here. This is the venous image, and often this is kind of where you start to notice something if you don't have a great image, that what are all these vessels around, posterior to the head. This patient had a pretty severe celiac stenosis, and this is just to show you what the issues are. This is obviously the celiac stenosis here. This is an MR PC Viper trying to show the directionality of flow. So basically you can see in this patient who needed a Whipple and had a celiac stenosis, the flow was coming down the SMA, retrograde up the GDA, and then into the liver, and then over into the splenic and into the stomach. So when we sacrifice the GDA and a Whipple, all of this stuff comes out, which now means this, the stomach, the spleen, and the liver don't have any arterial flow. And so it's fine if you know this ahead of time because you can plan for it. And then you can see in this case, there's an arterial graft replacing it because this patient needed a Whipple, but we were planning and expecting this. And so this is just a jump graft off of the SMA onto the hepatic itself. So celiac stenosis, even in the absence of these obvious collaterals, I think is something we should really seek and rule out on every case before we go to the operating room. Okay, what about the veins? Obviously everybody talks about whether there's portal venous abutment and if it involves the portosplenic confluence or the S&B and which part. But the places I think that are really important for us surgically, because we can deal with a lot of lateral wall abutment. It's really if it involves the caudal part of the vein down here in the mesentery itself. So we are always wanting to know, is the first jejunal vein branch, and it's not really a branch, of course, because it's coming this way, but the first jejunal branch is what it's usually called, but does it go behind the SMA or in front? If it's in front, it's more accessible. And I'll show you some examples of this next, but a posterior first jejunal brain branch is normal. And I think the vast majority of people have that. And then we're also always looking, where's the IMB? Is it coming here? Is it coming into the SMB? If there's involvement in that, how many branch points will we have? And then this is another pretty relevant surgical landmark, which is the insertion of the gastrocolic trunk, or at least the gastroepiploic vein, often forming a trunk of Henle, or having a common insertion with the middle or right colic vein. And then how big is the ileal branch? How many branches are there? This is really gets into the reconstructability and how much venous return you're willing to sacrifice for a given tumor. And I think that's will be illustrated in one of the cases.
Dr. Winslow, I have a question.
Yes.
So I know I always talk about the first jejunal branch, but what is the relevance of that gastrocolic trunk of Henle? Like, what should we be describing? And
well, I should have started with this. I'm not sure you all that it's all that important to describe everything. I wouldn't say at all like, oh, this is a template where we should describe everything. But the relevance of it to us is to know where is it in the area of involvement, for example. And are we going to, like, if we're going to be doing a vein reconstruction and there's a gastrocolic trunk that we're kind of obligated to take as a single unit at times, are we going to be taking the outflow of both the right and the kind of left part of the colon? You can get away with that, but in general, you have to maintain a certain amount of venous return back from the midgut. And so I'm always thinking of it more in the venous return issue for reconstruction. The other reason it's relevant is just because we know we're going to ligate it, and if tumor is involved in it, it becomes difficult. So it's one of the difficult parts of the operation. If there's tumoral involvement of the vein, the insertion of this, let me go back. The insertion here, sometimes this is a hard place to get to and can result in a shearing injury to the lateral aspect of the SMB. So it's kind of for both those reasons. But I didn't mean at all, I should have said this first, to propose like these are all things that should be described. There are things of interest, and I think what makes looking at the films fun, but it's not, I don't think all of these things need to be described. But just so everybody is anticipating the same type of questions and view of why we care, why we're always asking that annoying question. Okay, this is an example of a patient who needs a venous reconstruction, who has a neck tumor, and you can see that this is a splenic vein, this is the IMB, this is a first jejunal branch, this is the rest of the SMB, and then the portal. So in this patient's case, this is an anterior vein that makes the reconstruction. I tried to show you here on the axial. This is that first branch. And this is the SMA. So this is a nice anterior branching vein. And if we need to get control of the vessels here and here, it's a much different situation than if this were going behind the SMA. Okay, so, and then here, this is the case I'll show you, but this is an example of an involved large first jejunal branch here coming, sweeping behind the SMA here. All right, so the other thing, I think some of you may be familiar with this international consensus paper. This is basically essentially trying to get people to describe in some way and be on the same page about how caudal or cranial the involvement in the mesenteries of the SMB. I'm not sure I love this because the duodenum isn't necessarily constant relative to the branching pattern, but the idea is that we say this is group A, this doesn't exceed the superior border of the duodenum, this is group B, it doesn't exceed the middle, and so on. The inferior border, it goes below the inferior border. The point is, the lower it is in the mesentery and the more branches that are involved, the less it becomes reconstructible. So I think it's important to think of it along this line. I don't think this picture is great because it makes it look like it's one tube all the way down, and it's not. As you get down here, there's increasing numbers of branches, obviously. Okay, so what about the mesocolon? This is, I just wanted to show you this specimen so you have an example. This is a duodenal GI stromal tumor growing through so this is the right colon here, this is the transverse colon coming across, and you see this tumor is growing through the mesocolon. So even though it doesn't involve the colon itself, this does involve the ileocolic branches. They're coming kind of along here, and so for that reason we would anticipate in advance that the colon would need to be resected. But there are other cases like this one where it's really just a tethering of a single point along the ileocolic arcade quite proximally. The tumor itself is somewhere in here, I don't actually even remember it, but some type of pancreas head cancer. But the tumoral kind of puckering of the mesentery can result in a right colon for that reason. So this is, the TI and the right colon here, and just a standard Whipple specimen. Okay, and then aberrant biliary anatomy is important for a couple reasons. We're usually planning to cut the bile duct somewhere around here, so knowing about a low-lying insertion of a right duct is very helpful to us in advance, so we don't discover in the operating room the need to have 2 anastomoses, because sometimes we do have the option to cut these as a common channel. You can see that obviously. Sometimes I love this type of CT where you can, the stent isn't working that well, so you get a nice cholangiogram as well. And this is another place that can get us in trouble. This is in the gallbladder fossa where you can see the low-lying posterior duct. And so when we're doing the cholecystectomy, if we suspect this, we're obviously thinking about it a lot differently than in a standard cholecystectomy in terms of the risk of injury to that. Okay. All right. So what about issues at surgical reconstruction? You know, people do this operation a lot of different ways. And I think the take-home point is really figure out when you're looking at a film how it was done as much as possible in that case, because it really helps. And I'll just go through a couple of those. So obviously there's a standard and a pylorus preserving reconstruction. Usually the only difference in these is just how much, you know, where is the connection to this part of the stomach or to the duodenum. The more important point here is just, this is often how the operation is done. I think probably 90% of Whipples in the US are like this, with a closed end of jejunum, a pancreatic OJ, a hepatic OJ, and then a gastric J. But how it gets like this is not, you know, the picture is nice, but then you don't, there's many things you don't quite know yet, which is where's the mesocolon? Is the stomach in front or behind the colon? How did the bowel get here in the first place? And so that, I just wanted to go through that. One thing I think important is terminology. Often this is described as the roux limb or the afferent limb, efferent limb or something. I think the easiest thing is just to call this thing the pancreaticobiliary limb. It's not a roux, although you can make a roux for a Whipple. Most people don't. And so to be a roux, there has to be a jejunojejunostomy. That's by definition. So if there's not one of those, it's not a roux. And then should you call it the afferent loop? I don't know. It depends, like, what's your point of reference? Is it the stomach, the bile duct, the pancreas? So I think the simplest term, if this is the reconstruction technique, is just to call this the pancreaticobiliary limb here. And then remember, there's a compartment. Can be brought through the transverse mesocolon, as I've drawn it here, or sometimes it's brought through the duodenal space, the native duodenal space where the bowel was resected. You can bring the limb back through there. And then you don't have a place where it crosses the transverse mesocolon. And the same with the stomach. The stomach can be in front of the colon, in which case the mesocolon doesn't influence it, or it can be brought retrocolic through the mesocolon. And so then you can see this type of effect where often you can see like an hourglass at the place where the mesocolon is inserting. Then there's stenting. We can have external pancreatic ductal stents that look like this, the tube going, this is intraluminal through the anastomosis, through the bowel, and then out the outside, or internal stents that do the same thing but are just a small piece. And these are fun because you can see them all over the place after surgery, either one. You can see this piece down in the stomach or colon or whatever. Often they don't stay where you leave them. These are postoperative plain films that just kind of give, I think, a nice idea. You can see this NG tube going right into the limb, the pancreaticobiliary limb. So here's the elongated stomach here. This, you can see the 2 limbs of the loop that's coming up to the stomach, and the NG tube in the wrong one. And then here you can see a pancreatic ductal stent as well. This is an externalized stent on the patient's side here that comes all the way through up the limb through the PJ and then distally. And similarly here, you can see the same thing. This is that elongated stomach. The mesocolon's about right here. And you see the NG tube into the inframesocolic part of the stomach. And then you see this nice pancreas stent too. And then the omental flap, I just want to show one picture of one that's not infarcted. They often infarct, so it's hard to find this picture. But this is a nice, healthy omental flap, and you can see the difference between the way this fat looks and then the way just the kind of mesenteric, the mesenteric fat looks in this location.
And when do you decide to use an omental flap, and what is it mostly to try to promote healing and decrease leaks, or what are you using it for?
I think most people are using it to contain leaks. I mean, I wish they would prevent the leak, but more it helps compartmentalize the leak. So obviously for us, the enemy is uncontrolled pancreas fistula, undrained, uncontrolled pancreas fistula that results in, you know, pseudoaneurysm and all sorts of other issues. So the idea is to try to create a cavity around your drain and to let the omentum go where the problem is. Obviously the omentum goes where it's supposed to go normally, except in the state when there's postoperative adhesions, and it can't. And so I think most people, the thought is, I need to put healthy fat in the area. So some people do this with the falciform or the round ligament, and the preperitoneal fat, they'll use that'll come from the liver down, and then other people use the omentum if there's plenty of it. So I personally think many people do this every time because it's easy to do, and it generally doesn't hurt unless you haven't seen, you haven't pedicalized it enough that it can tolerate a little infarct. The patient's not sick, but a big infarct, often you can get a fluid collection, like the case you reviewed a couple weeks ago. So I think, the risk of doing it is almost nothing, and the time it adds is really small. So I think the vast majority of people who do a high-risk pancreas anastomosis will put this in. Not put it in, but it's literally like 3, 4, or 5 sutures you just sew. There's different ways to do this. I can show you at the end if you're interested. Okay, so anatomical issues and surgical reconstruction. I think the easiest thing is just talk to somebody who did the case, a resident. This used to be, now that we don't, well, pre-COVID, when we still just looked on the packs from our offices, it's so much easier just to go down and draw a picture, talk to somebody, understand, and agree what you're going to call things. This is an example, I think, where this is a more difficult case in a patient who had a gastric bypass previously and had, we needed to reconstruct their old roux limb and to say, look, this is what it was like before, this is what it's like now. So everybody's on the same page. Because in this case, there are 2 roux, a new roux and an old roux. And so when you're going through trying to understand, what's normal on the postoperative film, I think this is the easiest way. So I think this is something I think the trainees really maybe are losing out on a little bit, is that kind of way to go to the reading room and review things directly with the radiology residents. All right. Okay, postoperative imaging checklist. This is what's on my mind when I'm looking at a film post-Whipple, which is, of course, the thing everybody's thinking about. Is there a collection? Where is it? How many? Or how big? But I think the rest of the things, when this isn't there, often we're just happy and stop. But the things that need to really, I think, every time be looked at methodically are the state of the stomach, how the pancreaticobiliary limb looks, what the bile duct and pancreas duct look like, are the drains and stents in the right place, what's the GDA look like, what about the mesenteric venous system, the omental flap like we just talked about, and the incision. Obviously, this is in addition to the routine kind of look at everything within the abdominal cavity that you're doing. This is kind of, I think, the most surgically relevant stuff. So the stomach and the gastro J, I'm always wondering, is it dilated or fluid filled? What does the stomach look like? This is a case like the one I just showed you with the NG tube, where the stomach is coming through the mesocolon here. This is the part that's above the mesocolon. It's decompressed, and I can see the air in the limb going up and air in the limb going down until that oral contrast, in this case, which was given by mouth, not always, that has made it downstream. And then always is the NG tube way down here, in which case it's always draining a lot because bile physiologically is coming through here all the time. And then is the stomach still, has it been dislocated up into the above the mesocolon, or is it still inframesocolic? And then this is a great film. I love this film. This is a patient who was nauseated, got this film post-op, and often I'll tell you, this isn't alarming, I think, in usual kind of physiology, but post-Whipple, this is an alarming film, and almost always would get an NG tube for a patient who has needed a film for some abdominal reason to have a significant air fluid level in a post-Whipple stomach. This is also beautiful. You can see this nice air cholangiogram, and you can follow the pancreaticobiliary limb all the way here up to the stomach and down. Okay, so oh, sorry. Yeah, I think that's everything. Okay, and the pancreaticobiliary limb, we always want to know, is it dilated? I think if there's contrast in it, that's what this is an example of. Here's the stomach. This is downstream, and this is upstream. If there's contrast in it, there's something not right about it. It shouldn't be that way, right? In general, the bowel is peristaltic, and there shouldn't be reflux, significant reflux of contrast up the pancreaticobiliary limb. And then is there a change in the caliber of the pancreaticobiliary limb at the mesenteric defect, if that's the way it's been dislocated up into the right upper quadrant? And then is there any venous congestion in its mesentery, particularly if there's been sacrifice of some of the jejunal veins? Okay, so, and this patient was okay. He had cirrhosis, which is why he has all this ascites. Okay, the bile duct and the pancreas duct, we obviously, this is kind of an abnormal look most of the time after a Whipple. The bile duct should be decompressed. This was a patient who had a very large bile duct beforehand, and this was pretty soon after surgery, but still was a little bit worrisome that the bile duct wasn't decompressed completely. And then, are these in the expected location relevant to the bowel? So this is kind of a scary picture of the pancreas transection here. This is the pancreaticobiliary limb of the bowel here, and this is an internal stent, and there's this big space here. And that's obviously hard to know for sure what's happening in a CT like this, but in this case, we knew the patient had a significant pancreas fistula through this drain, and you could tell essentially that this was dehiscence of the anastomosis. And then is the pancreas stent in the surgical position, the position you left it or not, and are the drains, in or near the collection? So this is an internal stent going through the pancreaticojejunostomy with the drain nearby. And then the vessels. So every single time, I mean, I think honestly, this is one of the first things, at least I think is really important because it can really get the patient in trouble. But is the GDA stump aneurysmal? Is it healthy? Is it bathed in fluid? How long is it? Those things I think are really important. This is the same patient with two, I tried to show a series of them, sorry, but here's the GDA stump here, and you can tell that basically here's the clips at the end of it, and you can see the length of it. And then is the SMV or portal vein narrowed by a collection or at the repair site, and where is their thrombus? Is it in any of the branches, up in the liver and the splenic vein, some of the time? Okay, and then the omental flap, talked about that before, and then, you know, the incision, the fascia, the drains, etc., to make sure they're in the appropriate position. All right, so I am happy to show the case, or if you want to start with one of yours, we can do it either way. Oh, you're on mute.
Yeah, sorry. Why don't you go ahead and show your case, and then I'll take over the screen and I'll show a few cases.
Okay, great. So I'm going to move this here, and then I'm going to do this and this. Okay, so do you see this okay?
Yeah, that's
okay,
great.
Perfect. Okay, so I'm going to show you the preoperative film, and this is where I'm nervous now. There's a bunch of radiologists watching me do this. Okay, so this is the axial venous image of a patient who had a very large duodenal tumor. So I'll just kind of start at the top and then show you. This patient, honestly, he was symptomatic for months before getting this film, and had some, obviously, ascites ahead of time. He was losing weight and generally not doing great, but he wasn't jaundiced. So you can see his biliary tree is not particularly, not particularly prominent here. His gallbladder, however, is hydropic. And then you see, as you come down to the duodenum stomach to duodenum here, you start to see that there's this large thing with oral contrast in it. This is obviously the SMV. This is the main thing that kind of I showed you before, but you can see there's a couple of branches here. There's another one there, a big first jejunal or second jejunal, and here's the first jejunal here. And I'll just keep showing you so you can see the colon part of it. This is the colon. I'm gonna go back up. Sorry. Okay, yeah, so you can see the colon kind of right into this mass. So I'm happy. Why don't I show you the coronals, and then maybe take any comments or questions about the pre-op film to see what you all would have thought. Oh no. Okay, I'll have to refresh while you talk about it. How about that?
Any comments online or questions for Dr. Winslow?
Looks like a mass centered on the duodenum with communication or fistula to the colon nearby there.
Yeah, it was hard to tell where the contrast was coming from, but on the scope, it definitely looked very much like the duodenum was fistulized, if that's what you're saying, but definitely involved the colon.
It was almost like aneurysmally dilated. So one of the things I had thought about was lymphoma, although it sounds like you resected it, so it probably wasn't lymphoma.
Well, we had a biopsy ahead of time that was adenocarcinoma, but I think, yeah, I mean, it's obviously important to make sure it's not a lymphoma beforehand. And then I'll bring
Cookie.
Yeah, Cookie. What?
Oh, hi.
Hi, Emily.
How are you?
Oh, you guys know each other? Cool.
Actually, everything I learned from Cookie, so there you go.
That goes for all of us.
So that's very interesting about this afferent and efferent and roux situation of terminology. Boy, that's kind of alarming because that's
You've been calling them roux limbs?
Yeah, most of us ignore that, but yeah, it's not, right? A roux, you have to have an anastomosis between the small bowel.
So we as what I used to be teaching, and I'm corrected now, I used to call it afferent and efferent limb, except in the gastric bypass, and then I called it pancreaticobiliary and alimentary. So we should just calling it pancreaticobiliary and alimentary from now on for all reconstruction.
I mean, I think people know what you mean, right? I mean, this is where it gets down to that. But it is not, I mean, if you say afferent and efferent, it basically is assuming that everybody is using their point of reference as the gastrojejunostomy, kind of like a Billroth 2, right? But it's not a Billroth 2. There are multiple anastomoses. So when people are trying to say, well, it's between the pancreas and the bile duct that there's some transition in caliber, I think it just becomes confusing. But I mean, I'm not, you know,
No, that's
I
helpful. Thank you for.
yeah, I think in the end, it is, I think the ruthing makes more difference than afferent or efferent, but I don't think that everybody knows exactly what we're talking about if we use, you know, other terms. So that's where we say, can we just come there and look? Because I don't know what you're talking about. Yeah. Okay, so this is the film, sorry, this is the coronal. From a surgical perspective, at least my concern was this thing right here. This is, you know, if there's vein involvement at this juncture, we have this branch, and then only one more branch here. And then this is the ileocolic, and it's going to go because the colon's involved. So that leaves all the mesenteric venous drainage potentially that's coming back to the patient being this. And then presuming we, you know, have to sacrifice these two big jejunal branches. And then the IMV, which fortunately in this case was over into the splenic here. All right, see here. Yeah, so I can show the postoperative film too, if that would be useful. At least prove to you that we made it that far, at least.
What do you usually reconstruct with? Like the internal jugular vein or a synthetic graft or?
Yeah, I mean, it obviously depends what type of vein involvement that you have. If you need to take out a full thickness piece, you know, like the full circumference of the vein, often you can just put the two ends back together. You don't need an interposition unless it's long segment, so more than 3 or 4 centimeters. But to do that, you have to mobilize the root of the mesentery and the liver, and, you know, plenty of vein. But that I think is preferred, because then we're not in a situation where we have any graft in there at all. And usually there's much less caliber difference in that situation because you don't have a long length of vein. But if you need an interposition, I think that the left renal and the internal jugular are probably the best options. You can get the SFV from the leg, but there are a fair amount of leg related complications. You know, these patients are very thrombotic as it is. They get venous return issues, and I don't think it's wrong. It's often a good size match as well, but it's a little bit more challenging for that reason.
I didn't realize you could use the left renal, but so you're not sacrificing the left kidney, you're just taking a portion of the left renal.
Yeah, right, exactly. So, well, but I mean, we're sacrificing the venous drainage, but leaving the adrenal and the gonadal.
Okay.
So often the kidney will be okay. So, but yeah, that's a good size match, and you just have to have a long enough length and a good enough size. And that's, you know, that's something I think the preoperative images can help with a lot. Okay, so I'll show you, this is the post-op film. I can't remember exactly why we did this and how long, but okay, you can see the pancreaticojejunostomy here, and the drain in this case is this posterior JP. There's an anterior one too. It's a little bit harder to look at in terms of the staple lines, which are honestly for me this best surgical kind of guide to what limb is what, because I know what's stapled and what's not and that sort of thing. Like here, this is the gastric jejunostomy, and there's always a staple line on the lesser curvature there for me, and so I usually will find that. Here's the anastomosis. There's also there's a, you know, ileocolic anastomosis in this case, which makes the description of how we got the limb up into the right upper quadrant a little more different, difficult to describe than normal. And this is the staple line at the end of the pancreaticobiliary limb. So I'll show you the vein, because this I think is the part I was trying to get to. This is the SNV, so it comes down here, and then you see here, this is one of those jejunal vein branches, and I think I might need the coronals to show you the other. This is so actually someone called me and said, I think there's some clot in one of the mesenteric vein branches. We were like, that took a long time to make happen, to close this branch up. So we are happy about that there was a little thrombus in there, but the mesenteric venous drainage is still fine. Let me just show you the coronals, because that might be a little bit more useful. Yeah, so here you can see the IMV splenic vein there. And then here's where the difficult site was in the OR, and based on the tumors, you can see this first jejunal vein branch here with a little clot in it, and then it drains this way. And then, one other thing I forgot to point out, I'll show you, is this patient had cirrhosis, which was unknown to us preoperatively, but stupidly, I never noticed. So the patient had some shunting in the left upper quadrant. This was present on the preoperative films as well. So the patient had splenorenal shunting on the initial film, but you can see the splenorenal shunt here. And that was, the patient didn't have clinical evidence of portal hypertension or cirrhosis, but clearly had cirrhosis at the time of exploration. So anyway, it's just would have been a nice thing for me to notice beforehand. I don't know, maybe not, because I might not have done it. But anyway, so this patient ended up having a duodenal adenocarcinoma that was T4, was growing into the colon and into the pancreas, but 52 nodes, I think they described, none of which had metastasis in them, and a margin negative resection. Oh, there was the specimen. Okay, let me go back to that. I'll show you what it looked like. Okay, it's here. So this is the intraoperative, you know, after the specimen's out. You see, this is, it's not a very good picture, I'm sorry, but the ileocolic vein stump is here. And then this is where we've tracked that jejunal branch I was showing you that might be the only supply we had left, all the way up to the portal vein and the splenic vein here. And then this is the specimen itself. So you can see this is the normal Whipple specimen, a stomach, a pancreas head, and then the duodenum here with the ileocecal valve, right colon, and then left colon where there's a bunch of dye and omentum. You can see that area, the problem was all in here where the splenic vein, or sorry, where the SMB was coming down the venous groove here and the retroperitoneal part of it here. Yeah, so that's all I have.
Awesome. Okay, I'm going to show a few cases and we'll get your input. Can you all see my screen?
I see.
Okay, so this was a post-Whipple case. Patient also had a drain. And here, this is the pancreaticojejunostomy. So we can see the nice fluffy pancreas. And this was the staple line at the blind end of the jejunum. And we could see that there was fluid kind of splaying apart the pancreas from the jejunal anastomosis and almost that separation like you were showing in your image. So we were concerned about a pancreaticojejunal leak here. And we were asked to put a drain in, and what I've been told is to put a drain right at closest to the area of the leak so that we can dry it up, but not like so close that you're kind of propping open the pancreaticojejunal anastomosis.
Oh.
So this was our post drain. So we put it there and it nicely kind of dried up.
Mm-hmm. And how much time between those studies?
I think it was several days.
Yeah, okay. Yeah, I mean, I think that, you know, the location of the drain is, it's relevant. I mean, and particularly the management afterwards, like once you have it controlled, then you at some point will be backing the drain out. You can't just leave it in the same place and expect it to stop. You know, we're usually trying to get a cavity around the drain that then we can retract. And so it becomes, this is why I think it's actually easier for us to do this with a surgical drain that doesn't have a pigtail on it, because then we can slowly retract it as opposed to having to deal with the pigtail and not being able to have it come back in the cavity.
Yeah,
But,
I think in this case, the surgical drain wasn't draining it. So yeah, we had to go for it.
Exactly. Yeah. But that's a great case of just like an anastomotic dehiscence, really.
Yeah. And same thing. So this is the gastrojejunostomy. We just saw that staple line. And I think in this case, it looks anticolic. I think most of our surgeons go in front of the colon right there.
Yeah. Right.
This was, actually, let's see, this was another case. Actually, there was a lot of fluid. There was also a lot of free air. I was confused by this case because I thought, well, if there's a lot of free air, then there must be some kind of viscous perforation. I was wondering if maybe the blind end of the jejunal loop had opened up or some other, bowel loop. They actually went to the OR in this one because there was such a large leak with so much free air. And it was actually a leak again at the PJ. So here's a stent going across the pancreaticojejunal anastomosis. Even though there wasn't a lot of fluid right there, that's where the fluid was oozing out from. So I guess my question to you is, when do you decide to go to the operating room versus putting in multiple drains here? And I don't know, I guess I hadn't realized that you could get this much air leaking out of that pancreaticojejunal anastomosis.
Yeah, I mean, so when to put drains versus go to the OR? I mean, I think the most important principle is you have to contain leak and drain it. I mean, that's the only way to make this operation safe for patients who get a major leak, is to get it out of the vascular bed. So however you do that really, I think, depends on what's your window. How is this a patient who can tolerate, a period of kind of while you're draining the fluid? The patient's generally sick. You know, it takes several days to a week or two to get things controlled. And sometimes the patient is too frail. So elderly people or people that have a really significant leak and that already are sick from it, those people, I think in general, are the ones that surgeons want to take back to the OR to get ahead of it, as opposed to waiting for the patient to be sick. The air is funny because I feel like there's often, post-operative air that kind of looks like that in these older cachectic people with, kind of these rib cages that allow kind of ex vacuo type stuff to happen. And so I don't know, sometimes I get this call and I just think, please don't talk about it anymore. I think it's fine. The patient's fine, but other times.
Maybe this air was just post-op air.
I don't think there's any way for anyone to really understand this. Once there's fluid, of course, then that air, that the residual air that's still there isn't going to be absorbed as rapidly. So anyway, I think going back to the operating room, you can put a bunch of drains in. It's really hard to fix it. And in some cases, the best thing to do is actually just bail and get the rest of the pancreas out, complete the pancreatectomy.
Oh, wow. Okay.
Because salvaging something that's already leaking can be really difficult. So
yeah, they actually didn't, they said it was leaking from here, but they didn't redo the anastomosis. They just put multiple drains around it.
Yeah, it's already kind of digesting itself. And so then you're essentially doing what you could do percutaneously. The other reason, of course, to put drains in the OR is that there is no percutaneous window sometimes.
Yeah. And actually, this is an example of that pulling the loop through the duodenal normal track of the duodenum. So sometimes like we get confused, like, oh, why is there still duodenum here? But they pulled the duodenal loop in. So why do some surgeons pull it back like this and others go transmusocolic?
I mean, I'm sure like everything, there's a million reasons, like training and convenience and all of that. But I think, if you think of the actual like rationale, when the cancer, if it's done for pancreaticocarcinoma, when it recurs in the local bed most of the time. And so a lot of surgeons like to get the loop out of the recurrence bed so that the bowel doesn't become obstructed, because that becomes really symptomatic for the patient. They need a PTC and all of that, and the quality of life is bad. So putting it up away, and honestly, that's why I put the stomach over on the left side too, because what's worse than biliary obstruction is gastric outlet obstruction as you die. So it's better, I think, to get all the kind of most relevant kind of drainage issues away from the resection bed. But some people worry about that space because they think things will herniate through there. I've personally never seen anything herniate through the space. We don't close it, but the gastric J essentially blocks it because it's coming, retrocolic in that location. It's also some people think, well, that's where it's supposed to be, right? That's where your bile, and so it is tempting to do that. But I think, at least my experience is that the vast majority of people are bringing it up anteriorly through the mesocolon. You don't have a mesocolic defect in this case to create an internal hernia or something like that. So I guess that's another argument in favor of this approach.
Okay.
So I just have a question about that, because I have seen Peterson's hernias, internal hernias, through that space. So in essence, it is a Peterson space that's widened if it's not filled. So
you mean when the bowel's not in it?
Yes.
Yeah.
So I mean, you could have internal hernias, not transmesocolic, but Peterson space.
We actually just saw one through the mesocolic defect, where all the bowel went up into the right upper quadrant. So, I think either way you have a space. The question is, which one can you close better? I think the cancer part of it, the downstream consequences, at least.
I have seen one where the recurrence obstructed this loop as it was going under. So
yeah. And it can do the same, the other location, but it's just in the resection bed at that point,
This is just a quick show and tell pancreatico-jejunal leak again, and it can dissect up into the liver. Luckily, it didn't thrombose off the portal vein or anything like that. And we also drained this. And then just one more case. This one, there was, again, free air, free fluid, but we weren't sure what it was from, and we were concerned about the gastrojejunostomy, so we gave contrast. And it's a little tricky, but you can actually see that the contrast is going out, and I'll show you on the coronal too. So basically it was a leak from the gastrojejunostomy. This is the coronal. So here's your gastrojejunostomy. Here's the contrast going in, and then here it is kind of amorphously leaking out into this space here.
Yeah.
So it seems like that's less common than the PJ leak. And so I have two other questions. One about the PJ leaks. I've been told that the softer, like if the gland is not atrophic and the duct was not dilated, that has a higher risk of leak.
Yeah.
Like if you have a soft gland?
Yeah, so the risk, I mean, the risk factors have been studied like ad nauseum because we can't solve the problem. So people just want to identify the people at high risk. I don't know how it really helps us, but in general, it's small duct, soft gland, and then the things that are associated with that. And soft gland meaning fatty infiltration of the parenchyma. And some people have tried to use imaging features to say, okay, if the, based on the density of the pancreas, we can predict there'll be a leak. And then the location of the transection. So when you transect the pancreas further and further to the left, as opposed to at the neck, that's higher risk. And then the BMI of the patient, probably also to do with fatty infiltration, but also anastomotic difficulty. And then the underlying diagnosis. Yeah, so for adenocarcinoma and chronic pancreatitis, it's less than it is for neuroendocrine tumor or cysts for the same texture-related reasons. There's something called the fistula risk score. I think that's probably the most commonly used, but it just incorporates those factors as well as the intraoperative blood loss.
And today I have a really great workout for you guys that you can do.
Okay. Is someone asking a question? I can't tell. Okay, I have, let's see if the chat. Amr is asking, do we follow a particular protocol in postoperative cases?
What's the secret?
Imaging protocol?
Yeah, I think he's asking for that. I mean, we basically do, if the patient's not, their creatinine's okay, we basically just do a, with IV contrast. If we are suspecting maybe there's a bowel leak, we would give oral contrast, but we usually don't do that right away. Do you have any preferences?
We give oral contrast if it's within 1 month of the surgery, to get one-stop shop.
Yeah. I think a lot of times, some of this depends on the patient, right? Sometimes the patient really doesn't have an NG tube and can't tolerate anything to drink and doesn't have a J tube, that occasionally. And then a lot of times we're at least in a position of, let's say things aren't perfect, the patient's creatinine's not great. And if they have a fluid collection, we're going to drain it, period. Like we're just going to put a drain in no matter what, depending on the amount of fluid. So in those cases, sometimes the easier thing is just to facilitate kind of getting it done is just a straight non-con scan and then straight to IR. But I think you have to factor the clinical situation in as much as possible. It gets away from a protocol, obviously.
Any other questions?
Archie, do we have a paper on the post-operative and then this widening of the pancreatico-jejunal anastomosis? I don't think somebody's looked at that, like how wide it is, what, separation.
It shouldn't be that way.
Yeah, I mean, I've seen a lot of these leaks. I mean, we do a lot of Whipples too, so like I'm not saying my surgeons have a lot of leaks, but I know also that, like, for example, unless the patient's really not doing well, they don't even like to image because they don't want to see the leak. Like, and so, they kind of know, okay, there's going to be some small leak. We don't want to see it so that we're, just stressing out about it, or people are asking to put drains in it. But what do you think, Dr. Winslow?
I mean, I think there are, lots of different ways to approach postoperative care. It is true at times you have to decide, just because it's like, once it's in like the typing text of a radiology report, people, like, there's this inertia amongst, I don't know, largely non-surgeons, I think, most of the time, but to say like, well, it says there's an abscess, there is an abscess, you must do something. And I think that's actually why a lot of people say, I don't want to know, because I don't want everybody going around saying this patient has an abscess, and then we start acting differently about the treatment. So I think you have to decide based on the clinical status whether the patient needs a drain or not. And then of course, factor the imaging features in to say, well, I'm worried about this, so maybe I'm just going to re-image in 3 days, or something like that. Or I'm going to put the patient on an antibiotic, even though I wasn't sure I was going to do that. So it is information I think is good, but you have to be careful not to let it become treating the image.
So this was actually the case of that omental infarct I was showing you, and or I was telling you about, and we decided not to drain this. There was air here, but we thought that was likely due to just the necrosis.
You essentially can't drain that because it's just dead tissue. I mean, that's the problem. You have to wait a while until it liquefies.
Yeah. I think sometimes though people get alarmed, like anytime they see gas, like it must be infected or whatever. But we've seen this quite a bit with like things that are rapidly necrosing. Again, here's here's the jejunal blind end. Here's your pancreatico-jejunal anastomosis, and the fluid was nowhere, like not right next to it. So we knew that it was like the omental flap infarcting.
Yeah, I should have put a picture in about a patient whose total omental flap was just like all air, and alarmed everyone something's leaking, but really the thing just died, and a lot of it, all we saw afterwards was really air. And then we did nothing for a week or two and got another film, and it was fine.
RT, is that the first postoperative imaging?
Yeah, this was like the patient was still it was like, you know, within a few days after their Whipple, so they were still an inpatient. No, actually, sorry. I think they went home and it came back a few days later. So I think, yeah, it was in the first like week afterwards, and he was just having some mild pain. We didn't put a drain in, and now he's doing fine.
And do you see something like that and say, did you guys use an omental, like a big chunk of omentum there?
Yeah, I mean, this is sort of like how this whole discussion came up. Was I didn't realize how often they were using these omental pedicle flaps, and then we're like, yeah, we're using them all the time. And I'm like, oh, I guess I just wasn't seeing them, except when they've infarcted. But I've seen it a lot, for example, and when they do like a right hepatectomy, like, and then they'll put like a big piece of omentum over here so that the liver doesn't torque down. And then last week I showed that you can also, like, you know, they'll take a flap and put it into the pelvis during an APR or other pelvic resections. I just didn't realize they were doing them like during, you know, routinely doing them during Whipples. So that was really helpful.
Marty, I don't know if you want to show another one, but on my screen, I just put like the one with a bunch of air in it, if you're interested.
Sure.
This is not Whipple, this is a left pancreatectomy.
Can you share your screen again?
Okay, I have to do it. Yeah, oh, maybe. Let's see.
And if anyone has any other questions, please type them in.
All right, let's see here. This is a left pancreatectomy. Here's the transection margin, but this flap is similar. See how you can see the outline of it, and it just has a bunch of air in it. But
and do you always leave a drain?
That's a good question. For Whipple, yes. I mean, there's like ad nauseum about this, but basically there's data on both sides of it. I think probably you can avoid some patients having drains that have big ducts and firm glands, but there's a mortality risk in patients that you guess wrong in. And so that's why people have said, well, we'll use the fistula risk score. My feeling is once there's no leak based on the early amylases, you can take the drain out. It's much harder to have to put it back in a place you can't always get it. So yes, for a Whipple, for a left pancreatectomy, usually, but not always. You can see this drain was like under the omental flap, and anyway.
Yeah, a lot of our surgeons, I think, don't leave drains. And we were talking about during COVID, like maybe they would leave some more drains so we don't have to do as many drains, but.
Yeah, right. It's, you know, there's different risks that you take, you know, by putting or not putting them. So I think
one more question. When do you do the pylorus sparing Whipple versus, because it would seem it would be better to preserve your pylorus so that you don't have dumping of your gastric contents, right?
Yeah, well, I mean, yeah, I think that's like the argument that it's always better to take less or something. But it turns out if you look at the data, there aren't that many great studies in pancreas surgery, but there are a lot of reasonable studies comparing pylorus versus non-pylorus preserving strategies. And in general, it's a mix. Some seem to suggest that a pylorus preservation is helpful, and many suggest that it's harmful. And so I think that there's good reason for people to have a variety of practice here. And some people think routinely it's a good idea. I think other people tailor it to the patient and the disease. So for example, if it's, excuse me, a duodenal adenomatous disease, I don't like leaving any duodenum because you just are leaving tissue that previously had was the reason you took it out. If it's a really young patient who's going to live a long time, I think it is better to leave the pylorus and just dilate it a bunch at the time. But then sometimes those patients get into trouble too, and they can have reflux, into the stomach, and they have less easy way to eliminate the bile, so they get more bile gastritis. Anyway, so there are reasons, I think, based on the disease and the underlying kind of situation. So for example, EUS, some people really think that if you're going to biopsy the tumor through the duodenum, maybe you should take that piece of duodenum out, because there have been patients that have implants along that tract. I think in the end it's a wash. I personally do it. I never do a pylorus preservation to an older person who needs chemo, because I think it's easiest to get them on liquids and without a pylorus and then get them to chemo. And in a young, healthy person, I think it's fine to do it either way, and I generally preserve the pylorus. But I don't think you can argue that anyone's way is right, because the data is really mixed.
Awesome.
Yeah.
Okay, any last questions? Well, thank you so much, Dr. Winslow. Oh, wait, fantastic presentation. Thank you. That was from the chat box, and Cookie wants to write it up now. So.
What are we writing up, Cookie? Oh, you're on mute. You're on mute.
Yeah, I don't think I mean, there are, post-operative imaging of, pancreaticobiliary surgeries, but we don't, I mean, no one really, like, I didn't know much about this omental flap infarct that has gas. I mean, we've talked about that leak.
We try to hide these things.
Yeah, and we need the, the pancreatico-jejunal separation. I mean, like,
Yep.
we should be starting to look at that as one of the features of a helpful hint. And, the distal pancreatectomy leaks are a whole different ballgame, but they seem to be a lot more numbers than the Whipple leaks. And so, I mean, I think it seems like we do a lot of post-operative imaging more than we do preoperative, and then beautiful cancers, the tumors and things like that. But we should be concentrating on,
Yeah, and there's so many interesting like clinical factors. So like, when do you drain it? When do you like get concerned about all that free air and things like that? So
yeah, or that jejunum in the back. I mean, I just think like all these were like wonderful pearls, Emily. Thanks so much for.
You're welcome. I got them all from you, so.
I should have put it together when she said she was at WashU before.
She was a well-trained, overtrained.